Hi everyone. So let's go ahead and finish up this very last section of chapter 19 by taking a look at that second factor that is going to influence cardiac output. So remember we talked about cardiac output and how that should be an equal sign, how it equals heart rate times stroke volume. We talked about heart rate, we talked about the influence of drugs, hormones, and the autonomic nervous system. So now what we're going to do is we're going to take a look at stroke volume. Now let's first define stroke volume before we talk about the variables that influence stroke volume. Stroke volume is going to be the volume of blood pumped from a ventricle during a ventricular contraction. So it's basically how much blood is being ejected during that ejection phase of the cardiac cycle. So you guys went through the whole animation of the cardiac cycle. So you should have been introduced to the end diastolic volume and the end systolic volume, because these are going to be two factors that are going to give rise to stroke volume. So let's think about stroke volume and how it basically is the amount of blood that's going to get pumped out during ventricular ejection. That's going to rely on how much blood is in the heart right before we contract. How much can we get in that heart, in that chamber right before we contract? We want it to be as much as possible. The average is about 130 milliliters. And then it's going to be the difference of the in systolic volume, which is going to be the amount of blood that's actually left after the contraction in systolic volume. Because remember, systole has to do with contraction, so this is how much blood is left after contraction has occurred. And yeah, you will have a little bit of blood left in the ventricles after ejection has occurred, after contraction has occurred. So just a little bit. This number doesn't look like a little bit because it's almost half the amount of stroke volume. But that is going to be the things that stroke volume is going to rely on. So now let's take a look at the variables that influence all of these. Venous return, something new called inotropic agents, and afterload, that's new as well. So we're going to first take a look at venous return. It's exactly what it sounds like, right? This is the volume of blood returning to the heart from the venous network. So it's really how much blood is coming to that right atrium from the superior and inferior vena cava. And this is going to be directly related to stroke volume. Because the amount that's returning to the heart is going to determine how much blood we can actually push out of the heart and eject out of the heart. So it is going to determine the amount of ventricular blood prior to contraction because it's going to determine how much blood is filling up into the atria and then eventually into the ventricles after that. And I say when I talked about returning from specifically the right atrium from the superior and inferior vena cava, I mean, we kind of have to take a look at the very beginning of the circuit because whatever is returning at the very beginning of the circuit is going to determine everything that flows eventually from that left ventricle, right? So the volume, this volume that's returning to the heart is going to determine something called preload. So I have my nice little balloon right here. And venous return is going to be how much air or blood. Just think of my air as blood returning into my heart. Do you see when I put the air into the balloon, how it stretches my balloon walls? That's preload. Preload is the stretching of the heart muscle wall just before contraction, which is what I just did right there, right? So the pressure that's building up is going to stretch that heart wall before it's going to shorten. So that's preload, that's venous return. So let's take a look and see how they're all going to be influencing one another. So this whole relationship between venous return and stroke volume is going to be best described by something called Frank-Starling law, or Starling's law, either one. So his law is going to read, as the volume of blood entering the heart increases, there is a greater stretch of the heart wall, or basically it means that you're going to have a bigger preload. The more blood you can put into your heart, the bigger the stretch, and then that means the more stretching, you get better cross bridges, more cross bridges as well. And then what that means is that a greater contraction can occur from that. So that's Frank-Starling's law in a nutshell, and that's kind of what that little flow chart over there is going to cover. So whenever I push on so let's fill it up again, venous return. Preload, right? And then here is stroke volume. That's the amount that's leaving my heart, right? I have a little bit left, not a whole lot. That is going to be able to increase my stroke volume if I have the best venous return and the best preload that is occurring. It has to do with those cross bridges. The opposite is going to occur with a smaller venous return. You're going to have smaller preload, which means your stroke volume is going to decrease. So let's talk about how we can get the best out of our venous return. How can we increase it? Well, if I take a big breath and I push the air out of my lungs with a lot of pressure, then that is going to help increase my venous return. So venous pressure increases during exercise because what happens is that the muscles surrounding all of those vessels, those veins, are actually squeezing on it, and that's going in and pushing the blood up to the heart that way. Another thing is, let me empty my heart. Another way is to just increase the amount of time that you have to fill up the heart. So if I'm able to, if I have a longer breath that goes into there instead of these short breaths, then that's going to help fill it up as well. You accomplish an increase in time through a slower heart rate, because a slower heart rate basically means that it's able to fill up and then it will contract. And then it's going to contract. So it allows it to fill up and contract. And venous return is going to increase because you're able to fill it up as much as possible before you're able to contract. So let me decrease it again. That is venous return. So the opposite occurs. You get a decrease in stroke volume whenever there's lower blood volume. If you think about it, if you don't have enough air in your lungs to blow this thing up, then that means if you don't have enough blood inside of your circulatory system, then that's not going to fill up your heart enough. So obviously there is going to be that correlation to low blood volume, like with hemorrhaging, or a high heart rate. If your heart is beating so fast, it's not going to have enough time to fill up. And that's the problem with a higher heart rate, is you don't have a very high stroke volume. High heart rates can go in and decrease stroke volume. And that results in a smaller end diastolic volume, smaller preload, smaller stroke volume. So that's going to be consequential to your cardiac output. So that's why we have to have that whole balanced ventricular output. Remember, we talked a little bit about that that ventricular balance in the cardiac cycle. It's largely because of this Frank-Starling's law. You've got to make sure that as one side receives an increased volume of blood, it contracts more forcefully to get it out. If you don't, if you have this giant volume of blood, but it only contracts weakly, you're going to have this kind of leftover blood, and then it kind of backs up the system and it causes edema. It's kind of like filling up a bathtub with a whole lot of water all at once, but the drain on the other side, it can't drain on the other side. So eventually it's going to, flow out of the bathtub, which is not good at all. let's take a look at this inotropic agent. Again, don't get it confused with what we talked about with heart rate. So this root word right here, I know looking at it would have no clue, but it refers to fiber. So this is going to go in and alter contractility, or the force that your heart is contracting. So if you can get a stronger force, like whenever I fill this up, and I come up from behind and help it contract, that is going to give me a bigger stroke volume. So I'm going in and altering the contractility with these different inotropic agents. Really what's happening is something with the calcium levels at the sarcoplasmic reticulum. If you think about it, more calcium levels means more calcium to the troponin, and that means that you are going to get more cross bridges formed, which means a stronger force of contraction. So that's what's happening there. Let's take a look at a couple of ways that you can go in and increase calcium levels in that sarcoplasm. One of them actually relates back to, it works on the same kind of system right here. When norepinephrine is released, it binds to these beta adrenergic receptors, and look, more calcium right there, right? So it's going to work by getting more calcium in there, and that means more calcium's going to, but this is at a nodal cell, just to make sure you guys know that I'm circling this, like you can see what I'm circling on the screen. But just so you guys know, this is a nodal cell. Pretend like I am looking at a cardiac muscle cell, and this cardiac muscle cell, the beta receptors on the sarcolemma, and this whole system can work on that cardiac muscle cell. So that means calcium would come in and it would bind to the troponin, and then you would have more cross bridges formed. Thyroid works the same way as it does in the nodal cell, to where you just have an increase in those beta adrenergic receptors. And so that's how those positive, these are positive inotropic agents, because they're going in and increasing stroke volume. Digitalis works by increasing stroke volume as well. It's a cardiac drug, and it's used to, it goes in and strengthens the force of contraction as well. And it's used in certain heart arrhythmias, or used to treat low cardiac output. Let's take a look at some negative ones. Negative inotropic agents, they are going to decrease the available calcium level. So less calcium means less cross bridges, so that means a lower contractility. And that is going to go in, that's increased by calcium and hydrogen ions. Certain drugs like calcium channel blockers, that's another kind of blood pressure med that's used, but it goes in and blocks calcium channels appropriately so, right? So that means they don't open, so that means there is less calcium available. All right. Let's take a look, and well, let's go back. Less calcium available, that decreases contractility, which is going to decrease stroke volume. Got to take it back to what we are talking about here, right? Yes. Let's take a look at the very last variable. The very last variable, yes. Afterload. Afterload is going to be a resistance. So this afterload is not good for stroke volume at all. Afterload is the resistance in arteries to eject the blood by the ventricles. Resistance and ejecting blood by the ventricles do not go together. You don't want any kind of resistance when that's happening. That's kind of like this. If I did this, and I get ready, I went, sorry, that made me choke up a little bit, and I'm ready to contract, but I can't. Nothing's coming out because I have this resistance. My finger is still closing up the hole right here. Or let's say it's not completely closed up, but just a little bit. It takes a long time to get it out, unlike earlier when I was able to, open it freely. So afterload is going to be that resistance on I guess, the other side of the ventricle trying to get it out. So that can be atherosclerosis, lining the arteries. It can be stenosis of the valves because they're so stiff they don't want to open all the way. So it's some kind of pressure that's going against blood ejection. So it's definitely not good at all. So this is going to decrease stroke volume. Afterload is bad and it decreases stroke volume. And when this happens, it's going to go in and decrease cardiac output. So sometimes the body has to compensate by increasing heart rate. So you have this kind of irregularly elevated heart rate because of this afterload that's in and around the heart. So that's it. That's basically it, right? Cardiac output is going to vary directly with heart rate and stroke volume. So let's sum it up. As heart rate increases or decreases, so does cardiac output. It is going to increase or decrease. And it depends on those chronotropic agents. Remember, they go in and stimulate the SA node and the AV node. Stroke volume really has more to do with what's going on in the myocardium. With heart rate, we looked at the AV node and the SA node. With stroke volume, we didn't. It was mainly what was going on with those cross bridges. That was the first two, right? Venous return, inotropic agents had a lot to do with forming cross bridges and being able to contract that way. Afterload was going to, it decreased stroke volume by once the cross bridge is formed and tried to contract, it tried to stop it. So that is going to be how they are all related. And so increases in both stroke volume and heart rate are going to increase cardiac output. Decreases in both stroke volume and heart rate decrease cardiac output. So just like we looked at with this one right here, this is what happened with exercise, right? We talked about how these both went in and helped increase cardiac output, which is good. And then once we're done exercising, then we can go in and get that back down to resting cardiac output levels. But again, these two, did not mean to do that. These two are going to kind of play off of one another and will fluctuate really just to make sure that cardiac output stays where it needs to. If stroke volume does, like I said, with afterload, if stroke volume does decrease, then the heart rate is going to increase to make sure that this doesn't drop. So it's constantly a fluctuation as to which way it's going to go. So, talking about heart rate, let's take a look at the different heart rates. Whenever you have a persistently low resting heart rate, that's bradycardia, 60 beats per minute. Again, this can be normal in athletes, but if you're not an athlete and you have and you do have bradycardia, it can be from hypothyroidism. Again, if you think about going back and taking a look at how thyroid hormones, if they go in and they can stimulate nodal cells to increase heart rate, think about what happens when you don't have enough thyroid hormone. It will go in and decrease heart rate. Electrolyte imbalances, especially ones that are going in and playing around with the calcium levels and potassium and sodium levels. And congestive heart failure can cause bradycardia as well. Tachycardia, think about race cars, right, with the tachycardia. That is a persistently high resting heart rate, over 100 beats per minute. That can be common with heart disease. It's common with fever and also anxiety. So, the sympathetic nervous system comes into play a lot with tachycardia. So that is it for our chapter 19. We're not going over the development of the heart, that very last chapter. It's super interesting. We do take a look at it a little bit when we look at the development later on in the semester. So if you are interested in looking at it, definitely go in and look at it. But like I said, we will touch on it just a little bit when we go into growth and development at the very end of the semester. So until next time.